All right, thank
Grace, you're muted.
per usual. Thank you. Um, Welcome to the session of the 2026 Culture of Data Conference. My name is Grace. I will be your moderator today. Taylor Bostic is our tech host. She's in the background. She's that COD breakout room screen that you see there. She's making sure everything runs smoothly tech-wise. Everyone's muted right now. But at the end, there will be time for a Q&A session, so please feel free to unmute at the end there. And while we're listening to our excellent presenters today, feel free to pop questions into the chat, and we will make sure to get to those during the Q&A. Um, if you haven't already and you want to, please rename yourself. Add your pronouns if you'd like. You click the three dots in the corner of your little square, and you can rename yourself. Um, I have the pleasure of introducing our session sponsor, Connect for Health. Um, Clearly, we love our sponsors, and they make this happen. We couldn't do it without them. So thank you so much, Rachel Peters and Danny O'Neill from Connect for Health for your support. Rachel or Peter, I'm sorry, Rachel or Danny, are you here today? Would you like to say a few words?
Yeah, I'll be introduce myself. Hey everyone, my name is Danny O'Neill. I'm here with Connect for Health Colorado. We are Colorado's official health insurance marketplace. Our mission is to increase access, affordability, and choice for individuals and small employers purchasing health insurance in Colorado. And just want to say thanks so much for having us.
Thank you, Danny. Thank you for Connect for Health. All right, we have one presentation today. They will have about 25 minutes for their work, and then we have 10 minutes at the end for the Q&A. Um, they are going to tell us about their two-year mixed methods studies examining the disproportionate impact that social inequities have on health outcomes in rural communities across Colorado. Today we have here Meredith Davis, Beck Furness, Alexis Harper, and Cyril Benuna presenting Rural Health Equity in Colorado, a statewide study. Go ahead, folks.
All right, thanks so much, Grace. Good morning, everyone. As Grace said, I am Beck Furness, and I am a senior policy advisor here in the Office of Health Equity at the Colorado Department of Public Health and Environment. All right, today we're really excited to present some findings from the office's Health Equity Report on health disparities and inequities for people living in Colorado's rural communities. We will highlight the framing of the data, the quantitative and qualitative approaches, the key findings, and then how we're engaging community in this report. But before jumping into that, I would like to ground us and provide some context. Next slide, please. All right, so at the health department, our vision is a healthy and sustainable Colorado where current and future generations thrive. And for the Office of Health Equity, our vision is that every Coloradan has equitable access and opportunity to thrive, regardless of who they are or where they come from. Our mission is to build partnerships to mobilize community power and transform systems to advance health equity and environmental justice. Next slide, please. So Senate Bill 181, which was passed in 2021, directs CDPHE to publish an assessment concerning health disparities and inequities in the state. And this assessment must show the impact of the social determinants of health on these disparities and then recommend strategies to address them. Our first health equity report on race and ethnicity is entitled Health Disparities and the Impact of the Social Determinants of Health. And this was published in 2023. Our second report on older adults is called Thriving in the Third Act, Health Equity for Older Adults, and this was then published in 2024. And then our third report, which we'll be talking about today, addresses health disparities and inequities for people living in rural communities across Colorado. And the office worked with a contractor, Groundswell for Good, to create the report. And this one will be published this coming summer. We're excited. All right, next slide, please. All right, so how did we begin to address these issues? First, we needed to define what rural means in the state. We selected a county designation system developed by the Department of Local Affairs. And a rural county has a population of less than 50,000 residents, or is a municipality with a population of less than 25,000 residents that's not adjacent to a municipality with a population of 25,000 or more. And using this system has several benefits. It was developed by a Colorado state agency. It assigned designations at the county level and distinguishes between rural communities with different characteristics. And then finally, it offers flexibility by allowing counties to petition the state for reclassification. The system includes 3 categories of counties: rural, of which there are 37, 14 rural resort counties, which are characterized by high seasonal population shifts, heavy reliance on tourism, and higher housing costs. And then finally, we have 13 urban counties as well. Next slide, please. So this map shows the distribution of rural resort, and urban counties across the state. Rural counties appear in yellow, rural resort counties are in blue, and then urban are in gray. And I just wanted to note that Hinsdale County was actually reclassified in December of 2025 after the main analysis for this report was completed. So the results include Hinsdale in the rural category. And it's also really important to note that 2 federally recognized tribes, the Southern Ute Indian Tribe and the Ute Mountain Ute Tribe, are also located in rural areas. Next slide, please. All right, so the quantitative analysis includes outcomes for health and social determinants of health. For the health outcomes, the report analyzes 20 indicators in the following categories. We have chronic disease deaths, injury deaths, communicable disease deaths, and health status. And there are also 20 social determinant of health indicators selected using the Healthy People 2030 framework. Now I would actually like to pass it on to Alexis, who will be presenting on our health analysis, our data analysis, and then key findings. All right, next slide, please. And thanks, Alexis.
Sure. Thank you, Beck. Good morning, everyone. I'm Dr. Alexis Harper. I am a criminal justice project manager with Colorado's Department of Public Safety, and I am also a Health Equity Commission member. To inform this report, quantitative data were gathered from multiple sources. Some secondary sources included 3 from CDPHE, the Vital Statistics Program, the Behavioral Risk Factor Surveillance System, and the Disease Control and Public Health Response Division. Data were also collected or gathered from the Colorado State Demography Office, the U.S. Census Bureau American Community Survey. And in the next slide, please, we'll discuss also some qualitative data that were gathered from many different sources. There were 12 key informant interviews with contacts identified in consultation with the Office of Health Equity. There were 8 focus groups, 6 virtual and 2 in person, with 60 participants in total. Participants included residents of rural communities, state agencies surveying rural Coloradans, local public health agencies, nonprofit or other community organizations serving people in rural communities, and American Indian or Alaska Native people living in these rural communities. Next slide, please. There was a strong community engagement and validation component to the qualitative analysis. The Health Equity Commission advises CDPHE and the Office of Health Equity on how to build a healthier, more equitable Colorado for all. Our commission helped recruit participants for interviews and focus groups. Once the data collection was complete, transcripts were reviewed to identify patterns that contextualize the quantitative findings, and emerging patterns were grouped into themes reflecting participant experiences and perspectives. Finally, these draft findings were shared with participants through a validation process, through webinars and feedback forms. and we were pleased to find that participants affirmed the analysis. Next slide. The findings from both the quantitative and qualitative activities speak to a complex story of health in rural Colorado. Of the 20 health outcomes examined in the analysis, non-rural resort communities fared worse than urban ones on 15 health outcomes, 75% of indicators, and better on 2, which is 10% of indicators. Rural resort communities fared better than urban ones on 13 health outcomes, 87% of those indicators, and worse on none. Next slide. The research also revealed many strengths of rural communities across Colorado. Rural resort communities fared better than urban ones on 87% of health indicators and 50% of social determinants of health indicators. Communities have tight social bonds and a strong sense of belonging. Community members are highly collaborative and help neighbors in need. Rural areas also have more social associations, such as civic organizations, civic centers, and religious organizations relative to the population. In addition, rates of violent crime are significantly lower than they are in urban communities. Next slide. Now, we'd like to show some findings for specific health outcomes. Compared to urban communities, mortality rates are higher in rural communities and lower in rural resort communities. This graph shows the mortality rate from all causes between 2021 and 2023 combined. Next slide. Here we see a map of Colorado showing that the southern and southeastern regions of the state had higher mortality rates than other rural regions. Now I'd like to pass it to Meredith, who will share some additional findings and how we plan to engage communities in the report.
Thank you, Alexis. My name is Meredith Davis, she, her pronouns, and I am the Community Partnership and Engagement Manager in the Office of Health Equity. So another important indicator is self-reported health status. This slide shows how adults in rural, and urban areas perceive their health. As you can see, those in rural areas are more likely to report their health status as being fair or poor. Next slide, please. So it is common to compare rural to urban, but it's important to look deeper as there are health disparities within rural and rural resort communities as well. This graph shows the mortality rate from all causes of death by race and ethnicity within rural communities. You can see that the rate varies across different races and ethnicities, with mortality rates for some groups significantly higher than others. Next slide, please. And similar patterns exist in rural resort communities. Next slide, please. One of the most important social determinant of health indicators is income. This graph shows us that in rural areas, nearly 1/3 of people live in low-income households, compared to 23% and 22% in rural resort and urban areas, respectively. Next slide, please. All right. Now this is my area of interest because this helps me frame a little bit of the engagement that I want to do. So we want to share a little more detail about some of the qualitative findings from the report because they really offer some depth to the quantitative findings that we just shared. Participants deeply value safety, belonging, and mutual aid. Participants reported they feel a strong sense of belonging and a shared responsibility for taking care of one another. Challenges related to social determinants of health create stark differences in health outcomes, particularly for rural communities outside of resort areas. Long trips to access healthcare can cause immense strain for people in rural areas, which can contribute to economic hardship, and that can cause people to delay or even forego healthcare. In addition to challenges common across rural communities, some American Indian Alaska Native Coloradans report difficulty accessing high quality and culturally responsive care, while people who speak a language other than English identified language access and bias as a significant barrier. Sweeping federal changes in 2025 and 2026 leave rural and tribal communities facing an uncertain future. Major changes to funding and eligibility requirements for federal programs like Medicaid and SNAP could profoundly affect the health of Coloradans in rural and tribal communities. Next slide, please. All right, so now that we have provided a pretty high-level overview of our report, we want to make sure you all are aware of our next steps, since I know everyone is going to want to hear about this report. That's my shameless plug for community outreach. So the Office of Health Equity will publish the report this summer, 2026. In terms of involving the community in the report dissemination, we are going to have an ongoing roadshow of presentations across the state. So if you would like a roadshow, you can get in touch with me. One of our primary goals is to ensure the data is accessible and useful to the community and to community members. They also help inform equitable policymaking and programmatic initiatives. And then we will be publishing the report on the Office of Health Equity's website. So we will encourage you to check that out starting this summer. So looks like we are wrapping up before Grace can give me the signal. Next slide. We just want to say thank you all for coming to join our presentation, and we are open to questions or comments if you have any. Thank you so much.
Thank you all so very much. Folks, please feel free to raise your hand, unmute, pop your question in the chat. I have one to sort of get us started. You talked about sort of the next steps in one of your goals, making the data accessible and useful to the community and community members. Can you tell us a little bit about what that's looked like in the planning process and what it might look like in your next steps, how it's taking form?
Sure. I can at least go to the next steps part. Beck, do you want to talk a little bit about how that came into effect, kind of our planning around the report dissemination?
Absolutely. So I think what was really key was the validation process, was getting back to the community members who, especially who participated in both the focus groups and the key informant interviews. So via a survey as well as a Google meeting, the community members were able to validate that and say, this is really important, and just to reinforce some of their hopes as far as how policies would be implemented. And then as far as the roadshow goes, they were really interested in continuing the conversation. And that's where Meredith's team really comes into play in order to ensure that these issues are timely, they're at the forefront of conversations, and that they're actionable. So that was really, from that perspective, how we kind of continued from the data collection onward to the prospective next steps.
Yeah, and I just jumping in on kind of the next steps and the roadshow. We've been doing some work already with our existing health equity reports to go back to communities and share that information. And I think one of the key points is we're not just aiming to share the information with members of the community that match the particular priority population focused on in the report. One of the things we're trying to help communities see is the intersectionality of communities that have multiple factors that we may cover across different reports, but that those intersectionalities really do impact and compound the health disparities for some of these communities. I think the other important piece, and this is me speaking much more from a community engagement best practices standpoint, is I think it's very important not just to share our findings, but to solicit feedback, especially from communities that didn't have a chance to participate, or we just didn't have enough time to really get as many community members to engage in the qualitative process as possible. But this allows us to kind of go and continue to check that validation. So one of the things that I really like to see is how communities get this information and how they feel like it reflects their community, if it doesn't reflect their community, and what are some of the lessons that they would like us to learn that might inform how we share this report, might inform how we do future reports, and it also may help us get a better sense of the issues that communities identify that they themselves experience, which then helps me bring some of that information back into our public health state agency and help share that across other teams so that when other teams within public health are working on some very specific issue or process or program, they have some of that understanding so that their efforts with those communities can be that much more successful and effective because they come in with a better understanding of what the communities have identified as some of their biggest needs.
And then
So Grace,
one last thing I'll just add to that is for our subsequent reports, beginning in 2028, we're actually moving toward an interactive dashboard model where the data will be downloadable. So, as compared to having a really lengthy sort of PDF report on our website, this will be kind of a live option for folks to really like get that data, have it at their fingertips, and then hopefully take some action using it.
Great, thank you so much. And I'd like to follow up where you landed there. Speaking of action, if a county health department was, when a county health department is looking at this report this summer, because all of them will be seeking it out, like you said, Meredith, and they're looking at it asking like, okay, great, what do I do differently next week? Where do I direct myself and my coworkers and my teams? Where would you point them? What would be their next steps?
I think that is somewhat dependent on kind of where they want to take that and what they're interested in. So my approach typically is to really come into communities starting with curiosity and sharing that, I have information available to them, but I'm interested in really hearing from them. So in terms of how they see rural communities being affected by health disparities, I'd like to hear them be a little more specific about what areas they feel like the report maybe resonates the most with them, or what parts of the report are most relevant to them. And I think in some cases, some of this data is helpful, especially to rural organizations and rural health departments, as they explore the possibility of getting creative with funding opportunities, especially in the face right now. And I'm actually finishing up attending the Colorado Rural Healthcare Conference. So there's been a lot of talk about the Rural Transformation Grant that's going to be coming down. And in a lot of cases, we get interest from like public health agencies and other organizations about using some of this data in their applications for grants and other funding resources. So in some cases, I think the data can be helpful because they have access to the whole report and they can kind of pick out what's going to be most useful for them in terms of reflecting where they see the biggest challenges happening. And that way they can target funding that's going to help them address those. Um, in terms of, I think, wanting to learn more about the data and the data collection and the data sources, I'm going to probably at least start with one of the other far smarter members of our team who are very data oriented, and try to figure out kind of what data they're interested and how they want to use it. And then if they are interested in hearing the report and sending me away with thoughts and feelings. And how is this applicable? How is it not applicable? What would they like the state health agency to know? Then my effort is to go back internally and find other teams who I can either connect those communities with, or I can ensure that I'm bringing that message back and we're doing some internal education and information around how those programs can engage with each of those communities. So my very long answer is I think it kind of depends on what their need is and what their ask is.
Thank you. Fair enough. It depends. Applies in so many situations, doesn't it? Any other questions from the crowd? All right, I will get to our sort of closing announcements here. And while I'm talking, if you have a question, please throw it in the chat and or unmute or raise your hand. Um, Thank you, everyone. Thank you so much, presenters, for this work and for telling us about your work. Um, all of the handouts, slides will be available on Sched, so seek them out there if you're looking for them. Taylor has put up here our QR code for our conference evaluation. This information is so extremely helpful to us. The first thing we do is review the surveys from you all and make changes. We made lots of changes this year based on last year's survey, so it is valuable. We do use it. Um, so thank you for completing that. We've got a break for lunch now. Our next session starts at 12:15. So do your thing, have some food, have a walk, whatever you like, and we will see you at 12:15. Thanks again, presenters. Have a great day, everyone.
Thanks for having us. And please reach out if you want to hear about the report or have us come visit your community. Always doing shameless plugs for ourselves. Thanks.
Thank you, Meredith.